Welcome.
Thank you so much, Tony.
Appreciate you having here. It's great to connect with a fellow Chicagoan.
Oh, yeah, absolutely.
So before we dive in, why don't you just give me a quick, who are you? What do you do? What are we doing here? What do you want to talk about? And we'll just dive right in.
Sure. Well, I'm Douglas King. You can call me Doug. I'm a longtime Chicago architect, background in architecture. First job out of college, I started doing healthcare architecture, and 40 years later discovered I was still doing healthcare architecture. I worked for some of the larger firms in the country, firms like Perkins & Will and Hansel & Meyer. Did projects pretty much all over the U.S. and foreign countries, Asia and Middle East. And then I was, for 30 years, I was connected with a firm called VOA. VOA was a firm in Chicago that we got a very large project to work at the Northwestern Memorial Hospital. So I spent, of my 40 plus years, I've spent half of it on site at Northwestern Memorial in Streeterville doing about $1.5 billion worth of work.
Wow.
We won some awards for that. Actually, one of our hospitals was the most influential hospital in America in the last 25 years when it was given that award in 2016. That's the Feinberg Galter Pavilion. And through that, I became enamored with the idea of large-scale urban hospitals and how we execute these. So that's an area that I developed an expertise in. And then I have explored with the good graces of Stantec and a firm I worked with and some grant money, I was able to explore public health or population health as a research project and developed an interest and expertise, I think, in that area. And that's been honed since. In the last couple of years, I've moved over to the program management side of work, working for Project Management Advisors. We're a national project management, program management firm where I'm the national healthcare director. Started their healthcare practice 2.5 years ago with maybe 3 or 4 other people, and now we're close to 30 of our 200 people doing healthcare.
That's fantastic. I mean, it just made too much sense to bring you on today just to talk a little bit about the public healthcare sector, development, urban planning, because, the last 3 years, people have never heard of or considered urban planning and what impact that has on public health. And I think that when you get into the planning, design, and construction, our background in construction, you on the planning and design side, it just seemed like we could really bring the whole ecosystem together. So let's talk a little bit about, getting into public health in Chicago, particularly. We're both homers. Obviously, you've been all over the world, designed some incredible buildings and communities and community development, but you're still here. So our bias, obviously, is to throw this shameless Chicago's the best city in the world plug.
Of course.
But, with that, there are some things that there's room for improvement. So let's talk a little bit about what you've seen and kind of where things are going on the side of planning, development, construction, and design.
Absolutely. And I really appreciate that you're aware of the distinct connection between urban design and public health, because there's agendas. And at the core of this, if you distill it all down, the core of it is as follows. Cities typically are trying to attract young urban professionals to move into cities because they're going to be longtime taxpayers, active in the civic activities, and they're going to cause a vibrant community to exist. Interestingly enough, healthcare systems have a similar agenda, but for a different reason. Until about 10 years ago, hospitals were paid to do a service. They were paid basically to, if they fixed a broken leg, they sent your insurance company a bill, fee for service. 10 years or 15 years ago, it changed, and now hospital systems are accountable for the patients that they serve in their community. They take an active interest in people staying well. So their agenda in the healthcare systems is the same agenda as people that are civic leaders. And one of my quests is to help make that a commonly understood issue and to promote that there's a symbiotic nature there that really needs to be built upon. And so this began for me. I got very active in the Urban Land Institute in a group called the Health Leaders Network, which is an international group that you're appointed to basically explore ideas. And one of the people I got exposed to is a guy named Michael Chang, who's the head planner for the UK's National Health Service. And he developed a program to develop public health facilities in the UK, and he made it developer-centric. He focused on the developer community, and I found that to be fascinating and something that I've really wanted to explore further. So,
well, as somebody who, lives in Chicago, works in Chicago, and has appreciated the urban planning aspect, I have a 9-month-old at home, and my wife delivered at Prentice. So that's where we have the Northwestern connection. And one thing that I really appreciated with that model that you have had so much instrumental in developing is the fact that she can go to her OB on one pavilion and be there and have all of her checkups. And if she needs labs, needs imaging, all that's right there. Because I think my generation, especially, and moving forward with the Gen Z, is everybody kind of wants that live, work, play right there at their disposal. And as I think family, from the aspect of family planning as well, if people are going to potentially have fewer kids in the future, they're looking for all of those conveniences close. And I think healthcare understands that. And to be able to experience that with a life-changing event like having a child, to be able to see everything in one, or have everything in one location with your physicians, your OBs, it also creates a little bit of that interconnectivity where the doctors are now in this communal aspect where you don't have this lack of communication or things that don't translate from one part of the hospital to the other. And to experience that seamless transition from when we first found out we were expecting up to delivering at Prentice, all that being in that communal development is something to be said. So first of all, kudos to you. Thank you for making that easy for us. But, let's talk a little bit about, what are some of the things that still need work? Because obviously that's just one drop in the bucket of urban planning, but it's a much bigger picture.
Well, your example is a great example of an academic medical center model where there's academic medical centers like Northwestern Medicine, which is number 6, I think, in the country now, has education for its providers, obviously nurses and doctors, has research that's ongoing, and then they have excellent clinical care, which I'm sure you're experiencing. And so that idea has actually been expanded upon by organizations like the Mayo Clinic, who've actually decided or identified that a medical experience such as what you talked about is actually a destination for people to want to be in a community. And they're turning, Rochester, Minnesota has a whole program to become a destination city for medical care, medical experience, and personal health. And so what's interesting on that is other cities haven't quite gotten there yet. They've gotten there on the clinical side, where they see doctors and nurses and people go to the hospital when they're maybe not feeling well. The idea is to change that around and make it an experience that you have a relationship with your healthcare provider even as you're well. It becomes a healthy living experience. And that is the difference. That's a big difference, and that's a different attitude. But I think it's an attitude particularly people in the up and coming generations can embrace. They, more active, a lot of more interest in measurement. People measure their health more knowingly. And so there's a ready audience there that's ready to accept this change in attitude towards what it means for public health. And I hate to say this, but COVID probably promoted some of that because we suddenly realized that all of our health are interconnected. We're interconnected at the nanocell level. And so we by seeing that, we recognize that by being connected, it's in our common interest to have a true public health approach. What's both sad and enlightening is that during COVID as well, the idea of inequity in health access became very poignant. It was like a huge spotlight went on it. And then we realized that was in the works for probably about 400 years, okay? That ever since there was disparity in classes in the U.S., people were living in areas of cities that maybe had more pollution or less access to healthy foods, that kind of thing. And so there was an entire group of people that were being basically not having that access to good health, and it carried on from generation to generation. And during COVID, that was particularly lifted up. And it turned out that not only was it not access to food or maybe transportation issues or lack of hospitals, but it was the climate. It was the environment that was promoting poor health. And so there's a huge connection now between climatic change, environmental sciences, and healthcare that's emerging across the world, actually.
Well, and I think that's really interesting because I experienced that firsthand during the pandemic, because living in the city, obviously we take for granted that I can walk down the street in any direction and usually hit an urgent care that's sponsored by a good hospital or a good independent urgent care facility that has connectivity through, EMRs to the major hospitals if I have an issue. But what we realized very quickly is down here, especially in the south suburbs, where, people always ask me, like, where'd you grow up? And it's like really where the suburbs end and the farms start. And it's sort of like this transitional period where it's very different in just a period of, or a distance of 30 miles. And so I think what's interesting to see during COVID is I was talking to friends and family that at the time before we were realizing that we were going to vaccinate our way out of COVID, testing was really the only way for people to know whether or not they had it. Right. First of all, to begin some sort of treatment, through their physician or otherwise, but also to be able to travel, to be able to spend time with family, because this thing dragged on far further than 2 weeks to stop the spread. And the biggest theme that we heard was that there was no access to just basic testing because all the facilities were overrun. The traditional model was built around, we have ERs for critical care, but there wasn't enough urgent care because it was very much a primary care based model, but also the places that had access for that were extremely limited in the sense that the model was CVS and Walgreens were where you would traditionally go to get your lab work done. So now you have this perfect storm where people didn't know where to go or what to do. And we actually, as my previous company that I'm still involved with in healthcare was laboratory-based testing. So we said, why don't we try to do what we can to help the community? And we literally set up a COVID testing program in a church parking lot here in New Lenox. And it was inspiring that we were able to pull that off. But keep in mind, you want to talk about climate. It was November in Chicago. And we were testing people out of their cars because you didn't want to bring all these people into an enclosed facility, because that was the other part of planning and design with these facilities is now you're forcing people into a very cramped and crowded space during a COVID pandemic that is spread through the air. So you have an airborne pathogen, and the solution to try to mitigate the spread of this virus is to put people in very small facilities to get tested, and you don't know who has it and who doesn't until you get your results. And so for us, here we are out there in November in these parking lots testing people, and people were really grateful because they said flat out, they're like, there was nowhere to go.
Right.
And I think that as sad as it was for that kind of wake up call that we didn't have that, it's like you said, it's accelerated this urban planning and design, but also, I think what it exposes are some of these discrepancies in healthcare. So obviously living in Chicago, both of us downtown, there's a need to address healthcare for the homeless population. And I know that that's something that's really important to you. So why don't you kind of talk a little bit about some of the planning and design and how that's implemented for the other side of the equation in the homeless communities?
Actually, you touched on part of that solution. And when you mentioned about setting up a testing site in a church parking lot. I serve on the development board for an organization called, it's now called Tapestry 360. It used to be called Heartland Health Centers. They're what's called a federally qualified healthcare center. And this is really important and highly misunderstood in the healthcare industry. A federally qualified healthcare center is an organization that serves its community. In fact, 50% of its board has to be patients from the community that it serves. And these individuals, or this FQHC, gets enhanced reimbursements by the federal government to treat people who don't have resources, i.e. insurance and that kind of thing. For example, Tapestry 360, who I'm involved with, 90% of our patients live below the level of poverty, and many are immigrants and refugees. I have spent time in their facilities, and I've had the chance to interview, because I did a research project there, interview people who literally the week before were in the middle of a civil war in the Sudan, and this was the first time they were ever seeing a doctor in their life.
Wow.
So it's, that's what we're talking about here, is getting care to people. At the most grassroots level, it's people that don't have access either through, lack of funds or lack of locale. And so one of the ideas that we've been exploring, we have a project that will be starting up in New York City that may be a model for here. And that is there's in New York City, there's a lot of SROs, single room occupancy buildings, that are being converted to affordable housing or homeless housing, actually, by social agencies, because apparently there's funding there, et cetera, grants. And most of these have a ground floor retail of some sort, a bank or something. And we've come up with a model where we would basically put an FQHC type clinic or a portion of allied with an FQHC on the ground floor of these buildings. And then above that have affordable housing or housing for the homeless. There would be a synergy between the clinic and the residents. And the residents would actually be referred to these facilities through our hospital systems. And this is of interest to hospital systems because the single most expensive patient that shows up at an emergency room is a homeless person. Because you have no idea what they might be afflicted with. You have, no idea. They have no medical history, and many times there's mental illness involved, behavioral health issues. And so the question then becomes, okay, I don't say the question, I would say there's a value there that is very enticing, shall we say, for healthcare systems. I'm going to put it crass for a minute and put it in business terms of return on investment. They've done a study and they showed that a typical a homeless person, if you could invest up to $150,000 to $180,000 in their health over a 1-year span, treating various illnesses. Yet, if you provided stable housing for that individual within several months, their health stabilizes, and you've invested maybe $12,000 a year in rent. And so there's a huge financial benefit there for overall healthcare system, not to mention the truly altruistic, element of that.
Well, I think it's common sense. And I think that a lot of things in healthcare, especially in urban planning, don't make a lot of sense as to how they're trying to solve some of these problems, because even if you could throw unlimited money at these problems, but if you really don't address the root cause, and I think what's interesting is you're coming back to what you had said about climate change, urban planning, but then just access to affordable housing. Because if these people are out, especially in inclement weather like Chicago, where
like today,
exactly. Like today, I mean, you can imagine you go outside and you're cold in 10 minutes walking your dog. Imagine being out there 20, 24 hours a day.
That's right.
And not having access to basic things like being able to brush your teeth, or, you have a headache that's ongoing and you don't know where to go to get checked up. And I think a lot of times for the hospitals too, what's really tricky is these people come in, and a lot of times it's just out of a necessary for survival. Yeah. If it's really cold outside, they'll come in and they'll just say, hey, I have, something that hurts, my chest hurts, or these people just need access to a warm room. And they know that that's a place where they can get it. However, unfortunately for the hospitals, it's one of the most expensive places that they can go. But if there is really nowhere else to go, because these people, even if there are great homeless facilities across the city, how are you going to get there when it's 20 below at 2:00 in the morning?
Right.
So obviously these people traditionally will wander into an ED because it's always 24-hour access. So I love what you're saying, because I think that that's really enlightening that there's a much simpler solution to start, and the longevity and sustainability of better health outcomes are completely at our fingertips with little investment.
Right. And I would just underscore that the FQHC, Federally Qualified Healthcare Center, which I once was in an audience with 200 healthcare designers, and there were only 3 of us that knew what they were when I did a show of hands.
Really?
Yeah, I'm serious. That is part of this element because it provides high quality healthcare designed to treat individuals, who have struggles, and have multifaceted health issues, and have no resources. So, but you hit on this subject, and I think, it's something that I just wanted to share one last anecdote that came to mind. I'm in this group, the Health Leaders Network, U of I mentioned, and we have a gentleman who's an urban designer and a doctor in our group. He's Dr. David Rojas out of Colorado State, and he does research projects. And one of his cool research projects he did was he took downtown Barcelona. He's from Spain, and he got rid of every other road and instead made it a tree-lined pedestrian walkway with shops and basically studied the health outcomes on that in the control sample versus his proposal. And he measures his success by how many lives are saved. Okay. And he has studies out there showing the numbers of lives that are saved by reducing roads, creating more pedestrian walks, more urban, call it pedestrian friendly environments that actually create healthier places and truly save lives.
Well, I think that couldn't be more true to someone anybody listening that lives in the city and that has access to be able to walk places. We both live in Lakeview, Chicago, and it's such a wonderful place to live because even in some of the more inclement seasons when it's cold out, you still can step out and go walk to a great restaurant or a great bar or a great shop. And when it's really nice out, that's really when Chicago comes to life. I've lived in New York City and Chicago, and I think that having access to those things, you're a little bit more inclined to say, okay, instead of going out to eat and we drive 20 minutes where it's like, I walk to my car, I get in my car, I walk to my table, I come back. You're seeing more people that are walking to, these restaurants or going to different places. And then you're like, hey, we just wrapped up a meal. Let's walk around and check out some of the shops. And just the act of walking is such a major health benefit to so many people, to any person really. And to be able to have that better access, it makes so much sense.
I agree. And really to make this happen, there needs to be, and this podcast, by the way, is a step in the right direction of further enlightening a broader populace, the body politic that does design and construction in our industry, and I really am, one of the quests I've had here in the latter part of my career has been to be part of sort of an education movement. I've designed my life in the last several years to be on sort of like a walking academic medical center. I want to provide quality practitioner type services in healthcare. I also want to be an educator. I'm on the faculty at University of Kansas and also give annual talks in University of Pennsylvania and over in China, and do research. I've had the opportunity to do some research, and so there are a number of other like-minded people out there, people with these passions, and this podcast is definitely a place to sort out and find some of those folks.
Well, and I really appreciate you taking the time to come and talk to us. And I think what it does is it sparks ideas, most importantly. And it's in today's day and age where there's a lot of noise out there. And I think there's a younger generation that's hungry for information, but you have to also understand how a lot of people want to be communicated to, because we're constantly bombarded with advertisements and commercials and all these things. And life is busy enough as is in the modern digital world. So I think that for people to be able to unplug and listen to these ideas, the hope is it can spark other ideas. And so with the younger generations, kind of going back to something that you said that's been, stuck with me, is they love the healthcare outcomes where they have better benchmarks, where they understand their health. And I think to understand the catalyst to all this is Western medicine for quite a long period of time has always been a symptomatic treatment approach, meaning we come in, you have a symptom, we treat the symptom, we hopefully make this either mitigate it or make it somewhat better, and then off you go. What we're not looking at is the systematic approach as to why did this patient even get here in the first place. And I think what's wonderful about our health as human beings, as a species, is whether you are the 1%ers with the best healthcare insurance money can buy, or you're a homeless population with no health insurance and nowhere to live, we all want to live a long and healthy life. Right. And the reality is that is what connects us. So I think it's what the pandemic did too is when I was out there in the parking lot, we had people pulling up, with a family of 5 in the back in the Suburban, wanting to all get tested, and everyone was nervous. We had people pull up in Mercedes, so you see just kind of the culture of healthcare being everyone, and it's all impacts us in the same ways. And so as we look to the future, what do you see as kind of a really important takeaway with younger generations? Because, you and I are only going to be here for so long, and we have to make sure there's that passing of the torch in healthcare to make sure we keep progressing as a culture and as a species.
And I think, actually, I'm glad you asked that question because there's a challenge here. There's a pretty big challenge that exists within the AEC community, architecture, engineering, construction community, particularly in healthcare, that we need to address. And I think it's individuals who have the time in their careers to address this that's going to be the answer, i.e. a little somewhat younger. And it's getting past this idea. It's actually, I'll get to the point. It's engaging the developer community in the idea that when we do public health or when you do health projects, there's a public health element to that needs to be built into the program and can't be ROI'd out or can't be diminished in any way. And I got a few examples on this, but I have the opportunity, I speak, I'm going to say at least a dozen times a year at conferences. And last year, most of the conferences I spoke at were like-minded sort of public health savvy, or healthcare design type events. But I did have the opportunity to serve on a few developer-centric panels. Okay. And one in particular, I mentioned to the moderator in the pre-planning, the rehearsal, I said, I'd love to talk a little bit about public health on this and some of the things we had here. And he said, well, I don't think people in that audience will be very interested in that. Okay, I think they're interested more in the sort of hardcore numbers, programming, And I said, well, okay, I'll kind of go with the flow here. Well, they had one panel before us. There was my group, which was basically providers and consultants. And before that, they had a group of doctors and administrators in healthcare. Wouldn't you know it, you could guess what they talked about. They talked about the challenges of public health. Because that's and the audience ate it up. They ate it up. It was an audience of people that are developers or developer savvy folks. The idea that there was this enlightenment that to your point, we all feel as human beings. We all feel as human beings. And I think your point you made about that experience in the parking lot is a great it's a great example, capsulizing of what the experience is about that I'm really just realizing. And so I think that being able to train, basically what I'd love to do is do a cross-training session where people who got access, in the banking industry or in the developer industry, going to healthcare design conferences where we're talking about evidence-based design, or we're talking about urban design as a public health initiative, and then do the reverse. Have people who are talking about these ideas go to the events where people who actually have to carry them out and deal with the day-to-day struggles of the community issues or the achieving ROI to make the project feasible, and hear them out. Both sides need to hear one another because the answer is somewhere with a little bit of both. And to me, it's become a big aha moment in my career as I progressed along, that there's, there are people in the developer community who have a lot of power. They have a lot of power, and power being defined as the ability to get something done. And these individuals can get, when there's a need for example, I can think of a really noble healthcare project in the southwest side of Chicago that I would love to see built. And it's been held up because of lack of funding. Okay. But I'm thinking to myself, I'll bet if you put some creative people there in terms of the development community, they would find the funding, find the means to do this. Okay. And so we do that. And I think some of this training, it definitely starts at people, coming out of school or even in school, beginning to practice, because it's not just hands-on, here's how you do a project budget type of training. It's a mindset and an attitude. It's a mindset and attitude that when we're sitting with providers in user meetings, talking with doctors or nurses or administrators of public health, we understand what they're trying to achieve based on their experiences, which are not unlike your experiences in the parking lot.
Well, and I think to summarize, it's communication. It's what we're doing today, and I couldn't be more appreciative for every opportunity we can get to spread the message and to just talk about it. Because if all people do is get one soundbite that inspires them or encourages an idea to take place and to start developing into something bigger for positive change for all of us, that's really all that we could ask for. So I can't thank you enough for the time. This has been wonderful. I mean, I could sit here for days and we could try to tackle it, sector by sector throughout healthcare. But I really think this is a great jumping off point for people to learn a little bit about how what we do in construction, what you do in design, what our physicians are doing in diagnostic and clinical care, and how it all ties together. It's really encouraging. I think the future is bright.
Thank you so much, Tony. And this is such a great setting to be in, to have this conversation, and truly enjoyed it a lot.
Well, I appreciate it. Look forward to the next one.
Thank you.
All right. Take care.
Bye-bye.